Welcome to the Rad-On Smart Review GU Cancer Series.
Thanks for having me back.
Yeah, of course. So, imagine this scenario for a second. Your surgeon just performed like a flawless, perfectly curative surgery on a high-risk tumor.
Right.
The margins are totally clear. The nodes are out. I mean, the operation is technically perfect.
Best case scenario, right.
Exactly. But in doing so, they just permanently slammed the door on the one drug that could actually save the patient's life.
Yeah, that is the classic nightmare scenario.
Right. So today we're doing a deep dive into upper tract urothelial carcinoma, or UTUC.
UTUC, yeah, which honestly is a pretty rare disease.
Super rare. It makes up, what, maybe 5 to 10% of all urothelial carcinomas?
Yeah, right around there. You probably see it maybe once or twice a year in your clinic, tops.
If that. But, the oral board examiners are just obsessed with it.
Oh, they love it.
Because it's the ultimate test of whether you actually understand the physiology or if you're just, memorizing flowcharts.
Exactly, because it looks exactly like bladder cancer under the microscope, right?
Right.
But the risk stratification, the surgical logic, and especially the timing of your therapies, it's an entirely different universe.
Yeah, it's a huge trap.
It really is the ultimate cognitive trap for a radiation oncologist. I mean, you see the word urothelial on a pathology report, and your brain just immediately defaults to those muscle-invasive bladder cancer pathways.
They just go straight into autopilot.
Right. You start thinking about neoadjuvant cisplatin, cystectomies, adjuvant nivolumab.
Yep.
But you simply cannot do that here. The histology overlaps, sure, but the anatomy fundamentally changes the rules of engagement.
Completely.
The behavior of the tumor, the anatomical pathways of the lymphatic spread, and, most importantly, the functional physiology of the patient. It's all completely distinct from a bladder primary.
So I want to get straight into the clinical friction of this disease. Because like you said, it requires a complete pivot in how you evaluate risk.
Absolutely.
And to keep us anchored today, we have a specific case that's going to drive this whole session.
Perfect. Let's hear it.
All right. So you're evaluating a 68-year-old man.
Okay.
He has a 40-pack year smoking history.
Classic.
Right. And he presents to the urology clinic with painless, gross hematuria and some intermittent left flank pain.
Okay, so bleeding and flank pain.
Yeah. So his workup kicks off with a CT urography, and it reveals a 3.5-centimeter filling defect in the left renal pelvis.
That's a good-sized tumor.
It is, along with moderate hydronephrosis.
Okay, so it's obstructing.
Exactly. So then they do a cystoscopy, and the bladder is completely clear.
Good.
Yeah, so they move on to a selective upper tract cytology, and that comes back positive for high-grade urothelial cells.
Right, which you'd expect.
Right. Then a subsequent ureteroscopic biopsy confirms it. High-grade urothelial carcinoma.
Okay. What does the cross-sectional imaging show?
So it shows a borderline left periaortic node, but no distant metastatic disease?
Okay, so localized but high risk. But wait, you also need to scrutinize his vitals and labs before you even start to formulate a plan.
Oh, absolutely. So his baseline creatinine is 1.1.
Okay.
And his eGFR is 68.
Got it. 68.
Yeah, and he has an excellent performance status.
Sure.
But here is the critical piece of history that examiners will totally bury in the prompt.
They always do.
It's his family history. He has a sister who developed endometrial cancer at the age of 48.
Oh, wow. Okay.
Yeah. And a paternal uncle who had colon cancer.
Right. So that family history is a blaring siren.
It really is, and we're going to break down the exact genetics behind that in a minute.
Yeah, we have to.
But the immediate clinical dilemma you're facing is this. The urologic oncologist is planning surgery, right?
Right.
And they send the patient to your clinic, and they basically ask two questions. First, should this patient receive neoadjuvant chemotherapy before I take the kidney?
Yep.
And second, what is your role as a radiation oncologist after I operate?
Okay. Well, before you even open your mouth to answer the surgeon about chemo or radiation, you really have to understand the foundational biology driving this presentation.
Okay, break that down for us.
You have to understand why this specific constellation of symptoms, imaging findings, and family history demands an incredibly cautious staging approach.
Right.
You basically cannot prescribe a single treatment until you fully grasp the concept of field cancerization.
Now, I always hear that term thrown around, field cancerization, but usually, in the context of head and neck cancers with smokers.
Right, it's super common there.
But what's the actual mechanism in the urothelium? Like, is it just the whole tract gets the same smoke exposure?
Well, it's a combination. It's shared carcinogenic exposure and clonal expansion.
Okay.
So the entire urothelial lining, starting all the way up in the renal calyces, funneling down through the renal pelvis, the ureters, the bladder, and, out through the urethra, it's completely bathed in the exact same filtered carcinogens.
And for this patient, that's, what, 40 pack years of toxins?
Exactly. 40 pack years of aromatic opamines and polycyclic aromatic hydrocarbons from tobacco smoke.
Right.
The kidneys filter these toxins out of the blood, right?
Yeah.
And then those toxins just sit in the urine, highly concentrated.
Directly contacting the urothelium.
Right, directly contacting the mucosa. And this genetically alters the entire mucosal field.
So it's not just one bad cell.
No, not at all. Millions of cells across the entire tract have acquired early oncogenic mutations.
Wow.
Which is why you can surgically cure a tumor in the left ureter, right?
Yeah.
And then 18 months later, a completely new, genetically distinct primary urothelial tumor just pops up in the bladder.
Because the soil itself is contaminated.
Exactly, the soil is contaminated.
Now, tobacco is obviously the heavy hitter here, but the other classic exposure you have to look out for, especially on standardized exams, is aristolochic acid.
Oh, yes. That's a huge board favorite.
Right. It's historically tied to Balkan endemic nephropathy, where people were essentially eating bread made from flour that was contaminated with seeds from the Aristolochia plant.
Yeah, it's wild. It causes massive DNA damage.
Exactly. And
Yeah.
it creates this extremely aggressive upper tract urothelial field cancerization.
Yeah.
But beyond the carcinogens, I want to talk about the anatomy for a second,
Let's do it.
because this is the biological mechanism that explains why UTUC behaves so much worse than bladder cancer.
Right.
Think about the bladder like a thick, heavy-duty rubber car tire.
Okay, I like that.
It has this incredibly robust, multi-layered detrusor muscle.
Right.
So if a superficial urothelial tumor starts growing in the bladder, it has to, chew through a lot of dense muscle before it breaches the organ and escapes into the perivesical fat.
It takes a lot of time.
Exactly. It
Yeah.
takes time.
But, the upper tract is a completely different architectural environment. The renal pelvis and the ureters are not car tires.
What are they?
They're thin water balloons.
Yeah, exactly. The ureter has a mucosal lining, a super thin lamina propria, and a very flimsy, wispy muscularis layer.
Right. There is no thick detrusor muscle guarding the gate.
None. So because the wall of this water balloon is so microscopically thin, a high-grade tumor doesn't have to grow very deep before it becomes extraliminal.
It just pops right through.
Right. It invades the surrounding retroperitoneal fat or the highly vascular renal parenchyma much earlier in its clinical course.
Which perfectly explains why clinical staging in UTUC is just inherently imprecise.
It's so hard to stage.
It is. It often wildly underestimates the true pathological stage. Because, a tumor only needs to penetrate a millimeter or two in the ureter to suddenly be a PT3 or PT4 disease.
Wow, just millimeters.
Yeah, whereas in the bladder, a few milliliters of invasion might still keep it completely confined as a PT2 within that thick muscle.
Right.
This anatomical reality dictates why our diagnostic workup has to be so incredibly rigorous.
Okay, so let's get into that workup. We start with imaging, and the gold standard imaging is a multiphasic CT urography.
Right, multiphasic is key.
You need a non-contrast phase to look for stones, a nephrographic phase to look for renal parenchymal masses, and an excretory phase where the contrast is actually, filling the collecting system to identify the classic filling defects of a urothelial tumor.
Right. And if your patient has a severe iodine allergy or, terrible baseline renal function, an MRI urography is your backup.
But MRI is generally considered inferior
Yeah.
for visualizing those subtle urothelial mucosal abnormalities.
Yeah, it's definitely the backup for a reason. CT is better.
Okay. So beyond the imaging, I want to zero in on the cytology.
Yeah.
Because the urologist in our case went into the operating room and did a selective upper tract cytology.
Right.
And my instinct is always why put the patient through instrumentation?
It's invasive, yeah.
Right. Why not just have them provide a voided urine sample like we do for bladder cancer? It's so much easier.
I get that. But doing a standard voided urine sample for an upper tract tumor is basically like dusting the kitchen for fingerprints when the crime happened up in the attic.
Oh, that's a great way to put it.
The yield is just terrible. First, you have the issue of dilution, right?
Right.
The malignant cells that are shedding from a small tumor way up in the renal pelvis have to travel all the way down the ureter.
Mm.
And then they pool in the bladder, mixing with hundreds of milliliters of normal urine.
So they just get lost.
Exactly. By the time that sample is voided, the malignant cells are incredibly sparse. The false negative rate is unacceptably high.
That makes total sense.
And second, even if the voided cytology does come back positive for high-grade cells, it gives you absolutely zero spatial information.
You don't know where it came from.
Right. You don't know if those cells came from the right kidney, the left ureter, or just a tiny, flat carcinoma in situ lesion hidden somewhere inside the bladder.
So selective cytology solves the geography problem.
Exactly. The urologist feeds a catheter directly into the ureteral orifice of the suspicious side. They wash the exact area of the tumor with saline, and they aspirate it.
So it gives you concentrated cells from that specific site.
See.
But even with that, the ureteroscopic biopsy, like the actual tissue bite they take it, has a massive biological limitation.
It does. The ureteroscopic biopsy is highly accurate for determining the tumor grade.
Right. Grade is easy.
Yeah, it will reliably tell you if the tumor is low grade or high grade, which, is the most critical inflection point for your management tree.
Okay.
But it almost universally fails to give you the true depth of invasion.
And this is because of the water balloon anatomy we talked about.
Exactly. Think about it. The urologist is operating with tiny endoscopic biopsy forceps inside a structure that is only millimeters thick.
Right.
If they take a deep bite to try and capture the muscularis layer to prove invasion, they risk perforating the ureter.
Which would be a disaster.
A total disaster. They'd spill high-grade tumor cells all over the retroperitoneum, causing a massive complication.
So they don't do it.
Right. They deliberately take shallow, superficial bites.
Which means you go into your multidisciplinary tumor board knowing the tumor is high grade, but you are effectively flying blind regarding the clinical T-stage.
Yep. You're guessing at the depth.
Okay, so this inherent diagnostic uncertainty brings us right back to the patient's family history.
Oh, yes. The sister with early onset endometrial cancer, the uncle with colon cancer.
Right. We know this points to Lynch syndrome.
Strongly points to it.
But I feel like there is a tendency to treat hereditary genetics as like a secondary issue in oncology.
Yeah.
Something you refer out for later.
Right, an afterthought.
Exactly. Why is it an absolute board requirement to address this immediately in UTUC?
Because UTUC is actually one of the sentinel cancers for Lynch syndrome.
Really?
Yes.
Wow.
Particularly driven by mutations in the DNA mismatch repair genes, most notably MSH2 and MSH6.
Okay.
In the general population, the mismatch repair system acts as the spell checker for DNA replication.
Right.
So when you inherit a defective copy of MSH2, your cells accumulate replication errors, which leads to microsatellite instability.
And the urothelium is sensitive to that.
Highly sensitive. The urothelium of the upper tract seems uniquely susceptible to this specific pathway. Up to 10 to 20% of UTUC patients might have a hereditary predisposition.
10 to 20%. That's massive.
It's huge, and it completely alters how you counsel the patient about their future risk for colon and endometrial cancers, right?
Right.
And obviously, it changes how you test their family members.
So modern clinical guidelines now mandate universal tumor-based mismatch repair screening for these patients.
Universal. Everybody gets it.
You don't even wait for a family history anymore. The pathologist should be running immunohistochemistry for MLH1, MSH2, MSH6, and PMS2 on the surgical specimen automatically.
Right. And if a protein is absent, you send them for germline testing right away?
Okay. So to help organize this complex initial workup phase, I rely on a really straightforward mnemonic.
Let's hear it.
It's CTCH.
Okay,
Right.
CCH.
C stands for cystoscopy. Because of field cancerization, you absolutely must look inside the bladder to rule out concurrent tumors before formulating any plan. Right. A is for anatomy. This means multiphasic CT urography to map the entire collecting system.
Right.
T is for tissue. This reminds you to get selective cytology and a ureteroscopic biopsy for grade.
Crucial step.
And CH stands for check heredity, meaning universal Lynch syndrome screening.
The CTCH mnemonic. That perfectly outlines the required standard of care.
Good, yeah.
So, okay, you've completed the workup.
Right.
You know the grade is high, but the exact depth is unknown. How do you stratify this patient's risk to decide if they are, losing their kidney today?
Well, risk stratification in UTUC is a very rigid binary algorithm.
Right.
You are either low risk or high risk. There's absolutely no intermediate gray zone.
None.
And to be considered low risk, a patient must meet a very strict set of criteria.
Okay, what are they?
The biopsy must show low-grade disease. The tumor must be small, typically less than 2 centimeters.
Less than 2,
It
okay.
has to be unifocal, meaning just a single lesion. And crucially, the selective cytology must be entirely negative for any high-grade malignant cells.
That's a lot of boxes to check.
It is. If and only if a patient meets every single one of those criteria, they become a candidate for kidney-sparing surgery.
And kidney-sparing approaches would include things like endoscopic laser ablation via ureteroscopy, or maybe a segmental ureterectomy, where they basically just cut out the small diseased portion of the ureter and reattach it.
Right.
Because the entire goal is to preserve the renal unit. Since these patients often develop contralateral disease later in life, you want to save every nephron you can.
But you have to be absolutely certain the biology is indolent before you offer a sparing approach.
Absolutely certain.
Which brings us back to our 68-year-old case anchor.
Right.
He does not meet a single low-risk criterion.
Nope.
He has positive high-grade cytology. His tumor is 3.5 centimeters, not less than 2.
And he has hydronephrosis.
Right. Which implies the tumor is causing significant obstruction and is likely invading the wall. He is definitively high risk.
Definitively. And once a patient is categorized as high risk, kidney-sparing options are permanently off the table.
Totally.
The oncologic risk of leaving disease behind is simply way too high. So the standard of care surgical backbone becomes a radical nephroreterectomy.
Okay, so let's dissect the operation itself. Because the surgical technique directly impacts our radiation fields and our systemic risks later on.
Right.
A radical nephroreterectomy is not just a simple nephrectomy where you clip the ureter at the UPJ and take the kidney out.
Oh, far from it.
Right.
The surgeon must remove the kidney, the surrounding gerotous fascia, the entire length of the ureter all the way down into the pelvis.
All thing.
Yes. And, this is the most critical part, they must excise a complete cuff of the bladder wall surrounding the ureteral orifice.
Now, I have actually watched urologists do this, particularly with robotics, and the bladder cuff management is always the major friction point of the case.
Always.
So why is leaving a tiny ureteral stump so incredibly dangerous?
It comes right back to field cancerization and the flow of urine. If a surgeon takes out the kidney and the proximal ureter, but they simply ligate the distal ureter just above the bladder, they are leaving behind a segment of urothelium that has been exposed to the exact same carcinogens as the primary tumor.
Ah, I see.
Historically, when surgeons left the distal ureteral stump, the recurrence rate in that small piece of remnant tissue was massive.
Like how massive?
Sometimes over 30%.
Wow.
Yeah, the tumor just regrows in the stump. So to prevent this, the urologist must dissect deep into the pelvis, physically open the bladder, and carve out a circular cuff of the bladder muscle that contains the ureteral insertion point.
Ensuring the entire anatomical unit is removed en bloc.
En bloc, exactly.
That doesn't end there, right? The operation must also include a template-based regional lymph node dissection.
Mandatory.
And the specific lymph node basins they target depend entirely on where the primary tumor is located.
Right.
If the tumor is up in the renal pelvis, the lymphatic drainage goes to the renal hilar nodes, the pericaval nodes on the right, or the para-aortic nodes on the left. But if the tumor is down in the distal ureter, the drainage pathways shift into the pelvis, right? Draining to the external iliac, internal iliac, and obturator nodes.
Yep.
The node dissection is absolutely mandatory for accurate pathological staging.
It is. But, even after a perfect clean operation, there is one more vital step before the patient leaves the hospital.
Oh, right.
You must ensure the patient receives a single perioperative intravesical chemotherapy installation.
Okay, this is a massive clinical pearl that really demonstrates you understand the holistic management of the disease.
It really is.
So what is the biological rationale for pouring chemotherapy directly into the bladder right after a major kidney surgery?
Well, think about the surgery. During a radical nephroreterectomy, as the surgeon is manipulating the tumor, cutting the ureter, opening the bladder to take the cuff, microscopic high-grade tumor cells are inevitably shed into the surgical field and the bladder urine.
Right, it's unavoidable.
And remember, the bladder urothelium is already primed for disease due to field cancerization.
The soil is contaminated.
Exactly. So if those shed tumor cells settle onto the bladder wall, they will implant and grow into new tumors. The data shows that up to 30 to 40% of UTUC patients will develop a subsequent bladder recurrence within a year of surgery.
30 to 40%.
It's remarkably high.
Wow.
So by instilling a chemotherapeutic agent like mitomycin C or gemcitabine directly into the bladder via a catheter, either intraoperatively or within the first few days post-op, you are chemically destroying those free-floating tumor cells before they can implant.
That's basically a prophylactic wash.
Exactly. And it significantly reduces the absolute risk of bladder recurrence.
Okay, so the surgical standard is robust. You've got the radical nephrorectomy, en-bloc bladder cuff, template node dissection, and a perioperative intravesical chemo wash.
That's the package.
But if you are sitting in an oral board exam, right?
Yeah.
And the examiner asks you for the next step for the 68-year-old man, you say, I refer him to urology for a radical nephrorectomy.
Oh, you just failed the station.
You totally failed it. You have fallen into oral board trap number 1.
Big time.
Yeah.
Because you ignored his kidneys. You ignored the physiology.
Let's look at the numbers. Our patient has a baseline EGFR, the estimated glomerular filtration rate of 68.
Right.
He currently relies on 2 functioning kidneys to clear toxins from his blood.
Mm-hmm.
The moment the urologist clamps the renal artery and removes that left kidney, what happens to his renal function?
He instantly loses 50% of his functional nephron mass.
Half of it gone.
Just gone. Now, his EGFR is not going to drop exactly by half, down to 34, because over the coming weeks, the remaining right kidney will undergo compensatory hypertrophy.
Right, it works a little harder.
Exactly. The hyperfiltration of the remaining nephrons will pull the EGFR up slightly. But in the critical immediate postoperative window, which is the exact window when you want to deliver adjuvant therapies, his EGFR is almost certainly going to crash into the 40s.
And here is the pharmacological reality. Cisplatin is the heavy artillery of urothelial cancer.
It is the absolute best drug we have.
It's the most effective systemic agent we possess to eradicate micrometastatic disease and actually cure these patients.
Right.
But cisplatin is highly nephrotoxic.
Very.
To safely administer cisplatin without causing irreversible tubular necrosis and, throwing the patient into permanent dialysis, medical oncologists generally require a minimum EGFR of 60.
Right. Sometimes they'll cautiously push it to 50 and perfectly optimize highly hydrated patients.
Sure.
But if this patient's EGFR drops to 45 after surgery, the window for cisplatin is permanently closed.
It's gone forever.
Yep. And that physiological reality is the entire basis for neoadjuvant chemotherapy in UTUC.
Right.
You have to treat the micrometastatic risk of this aggressive disease while the patient still possesses maximal renal function.
Right.
Because if you bypass medical oncology, send him straight to surgery, and then the final pathology report comes back showing PT3 disease with positive lymph nodes.
Which is highly probable given his 3.5 centimeter mass and borderline imaging nodes.
Exactly. It's very likely. You are going to desperately want to give him cisplatin,
Right.
but you won't be able to. You burn the bridge by taking the kidney first.
Okay, I want to push back on the data here, though.
Okay, go ahead.
Because in muscle-invasive bladder cancer, we have massive level 1 evidence. We have huge randomized controlled trials showing a definitive overall survival benefit for neoadjuvant cisplatin-based chemotherapy.
We do.
But in upper tract urothelial carcinoma, we don't have those giant phase 3 trials.
Right.
The disease is just too rare. So we're largely extrapolating the bladder cancer data upward into the ureters.
That's true.
So does the lack of UTUC-specific randomized data weaken the recommendation?
Honestly, it doesn't weaken the clinical imperative.
Yeah.
Because the biological rationale is just too strong to ignore.
Okay.
Yes, the evidence is mostly extrapolated from trials like SWOG 8710 in bladder cancer, but it's combined with prospective phase 2 data in UTUC that shows excellent pathological complete response rates.
What kind of rates?
For example, trials looking at neoadjuvant gemcitabine and cisplatin in high-risk UTUC show that up to 60% of patients will have their tumors downstage to non-muscle invasive disease by the time of surgery.
60%.
Yeah. And nearly 20% will achieve a complete pathological response, meaning no cancer left in the surgical specimen at all.
That's incredible.
It is. So given the devastating reality of the EGFR cliff, the major guidelines, including the NCCN, strongly recommend neoadjuvant cisplatin-based chemotherapy for high-risk patients with good baseline kidney function.
So when the urologist asks, should this patient receive neoadjuvant chemotherapy, the answer is a definitive yes.
Absolutely yes.
You must involve medical oncology immediately. You use the golden neoadjuvant window to deliver the curative systemic therapy while his EGFR is still 68.
It is arguably the most critical multidisciplinary decision in the entire disease process.
Okay, but let's look at the flip side.
Okay.
Let's imagine a scenario where the neoadjuvant window was missed.
It happens all the time.
Right. Maybe the patient presented with life-threatening hematuria and clot colic, requiring an emergent nephrorectomy just to stop the bleeding.
Right.
Or maybe the initial ureteroscopic biopsy, undercalled the grade so they thought it was low risk, took the kidney, and the final pathology unexpectedly revealed aggressive PT3 disease.
Yeah, that's a very common scenario.
So now the kidney is gone, the eGFR is now 45. What is the standard of care for adjuvant systemic therapy?
Well, for a long time, we had absolutely nothing.
Nothing.
Nothing. Because these postoperative patients rarely had the renal function for cisplatin, the historical standard of care was simply observation.
Wow.
Yeah, we basically watched them until they recurred, and then we offered palliative treatments.
It's brutal.
It was, but that completely changed with the landmark POUT trial.
POUT. POUT stands for perioperative chemotherapy versus surveillance in upper tract urothelial cancer.
Right.
This trial is the absolute bedrock of postoperative management. Break down the trial design for us.
Okay, so the POU trial looked specifically at patients who had undergone a radical nephrorectomy and had either locally advanced disease PT2 through PT4 or node-positive disease.
Okay.
And critically, they had not received neoadjuvant chemotherapy.
Right, the golden window was missed.
Exactly. So they randomized these high-risk patients to either clinical surveillance or adjuvant platinum-based chemotherapy.
But wait, how did they deal with the cisplatin problem? These patients only had one kidney?
The trial designers brilliantly accounted for the renal function cliff. They stratified the chemotherapy arm based on postoperative eGFR.
Oh, that's smart.
Yeah. If a patient magically maintained an eGFR above 50, they received standard gemcitabine plus cisplatin.
Okay.
But if their eGFR had dropped into that 30 to 49 range, which, is the vast majority of patients.
It's almost all of them.
Right. Then they received a substitution. Gemcitabine plus carboplatin.
Because carboplatin is much easier on the kidneys.
Right.
And what were the results? Because historically, oncologists viewed carboplatin as vastly inferior to cisplatin for urothelial cancer.
Right, yeah. But the results were totally practice-changing. The trial was actually halted early because the efficacy crossed the predefined boundaries.
Really? Halted early?
Yes. Initially, POU reported a massive improvement in disease-free survival. The patients getting adjuvant chemotherapy had significantly fewer recurrences.
Right.
The hazard ratio was incredibly strong, heavily favoring the chemotherapy arm over surveillance.
But I remember when that data first came out, there was still a lot of skepticism.
Oh, tons of it.
Critics argued that delaying a recurrence with carboplatin was nice, but it didn't prove the patients were actually living longer. It was just, a DFS story.
Right, DSS story, that was the big debate. But here is the crucial update that you absolutely must know for contemporary practice.
Okay.
With extended follow-up, the POU trial data matured and confirmed a statistically significant overall survival benefit. Yeah. It is no longer just a DFS story. Giving adjuvant gemcitabine platinum, even if it is carboplatin, helps these high-risk postoperative patients live longer.
That's huge.
It is. It solidified adjuvant chemotherapy as the absolute standard of care for the neoadjuvant naive patient.
So if a patient skips neoadjuvant, has PT3 disease, and poor post-op renal function, adjuvant gemcitabine carboplatin is the undisputed answer.
Correct.
But I want to throw a wrench into this.
Do it.
Because the entire landscape of oncology right now is being consumed by immunotherapy.
Oh, yes.
In muscle-invasive bladder cancer, we have the Checkmate 274 trial.
Yep.
And it showed that giving adjuvant nivolumab, a PD-1 inhibitor, to high-risk patients after a radical cystectomy significantly improved disease-free survival.
It did.
It's a massive new standard of care.
Right.
So because UTUC is the exact same urothelial histology, the logical leap is to seamlessly apply the Checkmate 274 data to the upper tract.
Right.
Why shouldn't we just give everyone adjuvant nivolumab instead of dealing with cytotoxic chemotherapy?
Because the immune microenvironment of the upper tract might not mirror the bladder as closely as the microscope suggests.
Interesting.
It's highly tempting to generalize the data, but it really requires extreme clinical restraint.
Okay.
Yes, the Checkmate 274 trial did allow UTUC patients to enroll. They made up about 20% of the trial population.
That's a decent chunk.
It is, but when you drill down into the pre-specified subgroup analysis, the results were really sobering. The UTUC subgroup did not clearly demonstrate the robust, statistically significant benefit that the bladder cancer cohort showed.
Really?
Yeah, the confidence intervals crossed 1.0.
Wow. Why do you think that is? I
Yeah.
mean, if the cells look identical on an H&E slide, why does the immune system react differently to a tumor in the renal pelvis versus a tumor in the bladder?
It's a great question. We don't have a definitive answer yet, but there are some fascinating biological hypotheses.
Like what?
One major theory relates to embryological origin.
Embryology.
Yeah. The bladder develops primarily from the endoderm of the urogenital sinus, whereas the renal pelvis and ureters develop from the mesoderm of the ureteric bud.
Oh, wow. I hadn't thought about that.
Right. Even though they both differentiate into a urothelial lining eventually, their fundamental embryological roots are totally different, which might dictate a completely different baseline immune microenvironment.
That is wild.
Another theory points to tumor mutational burden, or TMB.
Right.
Upper tract tumors often have a different mutational landscape and sometimes a lower overall TMB compared to bladder tumors.
Which makes them less immunogenic.
Exactly, meaning they don't trigger the immune system as aggressively, so PD-1 inhibitors like nivolumab just have less leverage to work with.
Less fuel for the fire.
Exactly. Or, it could simply be a statistical artifact because the sample size of the UTUC cohort in the trial was just too small to capture the benefit.
So from a strictly evidence-based medicine perspective, your confidence in adjuvant nivolumab is significantly lower for the upper tract.
Definitely lower.
How do you actually navigate this in a multidisciplinary clinic?
I use it very cautiously and heavily caveated. Adjuvant nivolumab is a reasonable discussion for very highly selected high-risk patients.
Give me an example.
Well, for example, if a patient did receive neoadjuvant cisplatin, had their surgery, and then the pathology shows they still have residual viable invasive disease.
Meaning they're resistant to platinum.
Right. In that case, adjuvant nivolumab is one of the only systemic options left.
That makes sense.
But for the platinum-naive patient, you cannot simply swap out the proven overall survival benefit of the POUT regimen for the murky subgroup data of nivolumab.
So the systemic therapy algorithm is pretty tight.
It is.
Neoadjuvant cisplatin is the golden window. Adjuvant platinum is the POUT proven backup plan. Nivolumab is a nuanced secondary option.
You got it.
But if you're sitting there looking at this case as a radiation oncologist, you are likely wondering, when do I actually use my linear accelerators?
Yep.
What is the role of postoperative radiotherapy here?
This is where you have to firmly check your ego and de-escalate your expectations.
Okay.
Making adjuvant radiotherapy sound like a standard routine part of UTUC management is oral board trap number 3.
Trap number 3.
Yes. You absolutely cannot treat this like a rectal cancer where everyone just gets chemoradiation.
But wait, if a patient has a massive PT4 tumor that invaded the retroperitoneal fat and they had positive lymph nodes, the local recurrence risk must be sky high.
It is high.
So why wouldn't we routinely radiate the tumor bed and the retroperitoneal node?
Because the data simply isn't there to support routine use.
There's no data.
Very little.
Right.
The evidence for adjuvant radiation in UTUC consists almost entirely of small, retrospective, single-institution series spanning decades of really old techniques.
So garbage in, garbage out.
Kind of, yeah. Some of these retrospective cohorts suggest that adding radiation might improve locoregional control, sure, but there is absolutely zero level 1 evidence proving it improves overall survival. Furthermore, the retroperitoneum is an incredibly toxic place to radiate. The standard post-operative discussion must focus on systemic therapy, not local radiation.
Okay, I agree routine use is indefensible. But there must be specific, extreme clinical scenarios where you are justifiable in offering treatment.
There are.
When do you actually agree to contour a case?
I reserve radiation for scenarios where the local failure risk completely overshadows the systemic risk, or where a local failure would cause catastrophic morbidity.
Like what?
The classic indication is a frankly positive surgical margin.
Okay.
If the pathologist sees tumor cells right at the inked margin of the renal fossa, or if the surgeon documents gross residual disease left behind because, the tumor was invading the psoas muscle or the great vessels, radiation is absolutely on the table.
What about recurrences?
Yeah, I would also consider it for an isolated locoregional recurrence months or years after surgery, provided there is no distant metastatic disease and it has been vetted heavily by a multidisciplinary tumor board.
Okay, so it is a salvage tool or an extreme risk adjuvant tool.
Precisely.
Let's walk through the technical execution, because examiners will definitely push you on your setup and dosimetry.
Right.
Let's say you are forced to treat that patient with a grossly positive margin in the left renal fossa. Walk me through the simulation.
Okay, so setup requires a CT-based simulation. The patient should be supine, typically with arms above the head, to allow multiple beam angles without passing through the arms.
Standard.
But the absolute most critical technical step is image fusion.
Right.
You must rigidly fuse the preoperative diagnostic CT or MRI to your planning CT.
Because the anatomy is completely distorted.
Exactly. Once the surgeon removes a large kidney, the bowel and surrounding structures immediately shift into the empty space.
It all collapses in.
Right. If you just look at the post-op scan, you have no idea where the original tumor actually sat in relation to the vasculature.
You're just guessing.
Yeah, you'd just be guessing. So you use the pre-op scan to identify the exact preoperative location of the renal pelvis and the tumor extent, and you map that volume onto the post-op anatomy to create your clinical target volume, or CTV.
Brilliant. And what about the technique and the dose?
The technique must be highly conformal. You are using intensity-modulated radiation therapy, IMRT, or volumetric modulated arc therapy, VMAT.
You need those tight margins.
You need steep dose gradients to protect the surrounding organs. As for the dose, if you are treating microscopic residual disease, such as a high-risk operative bed with positive microscopic margins, the standard prescription is 45 to 50.4 gray in conventional 1.8 gray fractions.
Okay. Would you ever push it higher?
You would only consider escalating the dose beyond that if there is a clear, visible, gross residual mass that you are trying to definitively control. And even then, you are heavily constrained by normal tissue limits.
Let's talk about those constraints.
Yeah.
Because this is the dosimetric minefield of the retroperitoneum.
It really is.
When we treat pelvic malignancies like prostate or bladder cancer, we are obsessing over the rectum and the remaining bladder volume.
Right.
But when your target is the renal fossa or the periaortic nodes, what is the single most critical organ at risk? The OAR.
It is another trap to say the bowel or the spinal cord, although those are obviously important.
Right.
The absolute most critical OAR is the solitary remaining contralateral kidney.
The right kidney, in our case, anchor.
Exactly. We already discussed the precarious nature of this patient's renal function. He lost his left kidney. His remaining right kidney now has to perform 100% of the physiological filtration work for his entire body.
It is infinitely precious.
Infinitely. If your IMRT fields spill over the midline and deliver excess scatter dose to that solitary remaining kidney, you will induce radiation nephropathy.
And what happens then?
The glomeruli will scar, the filtration rate will plummet, and you will push this patient into permanent end-stage renal disease, condemning them to hemodialysis 3 days a week for the rest of their life.
It is a devastating toxicity.
It's devastating.
The standard constraint is generally keeping the mean dose to the remaining kidney strictly below 15 to 18 gray.
Yep.
And keeping the V20, the volume of the kidney receiving 20 gray, as low as humanly possible, ideally under 20 to 30%.
Exactly.
And as you mentioned, the second major OAR is the small bowel and duodenum, which are often lying directly anterior to the renal fossa and periaortic nodes.
Right. You have to respect the standard bowel constraints, keeping the maximum point dose below 54 gray to prevent perforation or obstruction.
So it's not simple.
Not at all. It requires meticulous treatment planning, daily image guidance with cone beam CT to ensure the bowel hasn't shifted into the high-dose region, and rigorous motion management, like 4D CT, to account for diaphragmatic breathing motion of the target area.
Okay, let's pull all of this complex biology, surgical anatomy, and trial data back together.
Let's synthesize it.
Let's formulate the final comprehensive recommendation for our 68-year-old case anchor. To review, he has a 3.5 centimeter high-grade tumor in the left renal pelvis, hydronephrosis, good baseline renal function with an eGFR of 68, and a borderline lymph node. What is the definitive sequence of care we are recommending to the urologist?
Okay, step 1. We recognize he is high risk and possesses the physiological reserve to tolerate heavy systemic therapy. We immediately refer him to medical oncology for neoadjuvant cisplatin-based chemotherapy to eradicate any micrometastatic disease while he still has 2 kidneys.
Perfect.
Step 2. Following chemotherapy, he undergoes definitive surgical consolidation. The urologist performs a radical nephrorectomy, complete with an en-bloc bladder cuff excision and a template-based para-aortic lymph node dissection.
Step 3.
Step 3. To combat the field cancerization and prevent tumor implantation, he receives a single prophylactic installation of intravesical chemotherapy, like mitomycin C, directly into the bladder in the immediate perioperative setting.
And step 4 for us.
Step 4. As radiation oncologists, we observe. We hold off on any local radiotherapy entirely unless his final surgical pathology report unexpectedly reveals, frankly, positive margins or gross unresected disease.
That is a masterclass in multidisciplinary management.
Thanks.
It perfectly balances the aggressive biological risk of the disease with the fragile physiological reality of the patient's renal function.
Exactly.
Now, to make sure these concepts are totally locked in for the boards, let's run through a quick board blitz.
Sounds good.
I'm going to fire off 3 rapid clinical scenarios based on what we've discussed, and I want you to give me the direct answer and the concise logical rationale. Ready?
Let's hear them.
Okay, question 1. You are evaluating a 65-year-old woman in clinic. She just underwent a radical right nephrorectomy for high-grade disease.
Okay.
Her final pathology shows a PT3 and 0 tumor. Critically, she did not receive neoadjuvant chemotherapy before her surgery.
Classic trap.
Right. Her preoperative EGFR was 72. Her postoperative EGFR drawn yesterday is 48. What is the next step in her management?
The answer is adjuvant systemic therapy with gemcitabine and carboplatin.
Right.
This is the classic UTUC postoperative trap. Her PT3 status means she is at high risk for systemic recurrence, and based on the POUT trial, she requires adjuvant chemotherapy.
But she can't get cisplatin.
Exactly. Because her kidney was removed, her EGFR crashed from 72 down to 48. She is no longer physiologically capable of safely clearing cisplatin.
Right.
Therefore, we utilize the specific carboplatin substitution arm that was validated in the POT trial. And crucially, we do not offer routine adjuvant radiation.
Perfect. Question 2. You are seeing a 58-year-old man newly diagnosed with a high-grade tumor located in the mid-ureter. He has excellent bilateral renal function. The urologist has him scheduled for a radical surgery next week. What is the single most important clinical question you must answer before he enters that operating room?
The question is, has he been evaluated for cisplatin-based neoadjuvant chemotherapy while both of his kidneys still function? You absolutely cannot let that patient proceed to surgery without a medical oncology consultation to address the golden window for systemic therapy. Once the surgeon clamps that artery, the opportunity for the most effective curative drug is lost.
That's spot on. Okay, question 3. A patient is 18 months out from a successful left nephrorectomy. They are currently asymptomatic, but a routine surveillance scan reveals an isolated, suspicious 2-centimeter soft tissue mass sitting right in the surgical bed of the left renal fossa. There is no evidence of disease anywhere else in the body. What is your immediate next step?
The next step is tissue confirmation and a multidisciplinary tumor board review.
Right. You can't just guess.
Right. It is incredibly tempting to see a mass in the surgical bed and reflexively jump to salvage radiation or immediately start a new line of systemic chemotherapy. But you cannot fly blind.
Yeah.
You must get an image-guided core biopsy to definitively prove it is a urothelial recurrence and not postoperative fibrosis or a different primary.
Very true.
Once confirmed, you review the patient's prior systemic exposures, their current EGFR, and their goals of PAIR in a tumor board before committing to complex, toxic, local salvage radiotherapy.
Excellent.
Yeah.
I think we have thoroughly dismantled upper tract urothelial carcinoma today.
That covered a lot of ground.
We did. We covered the water balloon anatomy, the genetics of Lynch syndrome, the surgical nuances of the bladder cuff, the vital neoadjuvant window, and the precise dosimetric constraints of the retroperitoneum.
Yeah.
But before we wrap up, I want to leave you with a final provocative thought regarding where this field is actually heading.
Oh, this is interesting.
Throughout this entire session, we've relied on a massive, life-altering surgical backbone, removing an entire functional organ and a major tube, simply because our initial ureteroscopic biopsies are too shallow to give us accurate clinical staging.
Right. We're operating in the dark, basically.
We are. We are taking out kidneys because we don't know the true depth. But as genomic profiling and molecular assays rapidly evolve, we are approaching a horizon where advanced liquid biopsies might change everything.
That would be huge.
Imagine a future where we don't need a deep tissue bite.
Right.
We simply analyze the molecular signatures and methylation patterns in a voided urine sample to determine the exact aggressiveness and depth of the tumor.
That would be a complete paradigm shift. I mean, if we can reliably map the biological behavior of the tumor non-invasively we might be able to identify a vast subset of patients with high-grade but fundamentally non-invasive disease who can safely undergo endoscopic kidney-sparing treatments.
Exactly. We would be able to preserve thousands of renal units without compromising oncologic outcomes.
It would completely rewrite the surgical algorithms we spent the last hour discussing.
It is an incredible technological frontier, and it really highlights how fast the biology of oncology is moving.
It does.
Until we reach that point, remember to protect that solitary remaining kidney, respect the EGFR cliff, and never let the overlapping histology of bladder cancer algorithms lead you astray in the upper tract. Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.